In this video, we are going to explain to you as to how we examine a diabetic patient who has got a foot problem. When we examine a diabetic patient with a foot problem, it's not the diabetic foot alone we are examining. We have to examine a patient who has got a foot problem. So it has got two components, examination of the patient and examination of the foot. In the history, we asked for the duration of his diabetes and duration of the ulcer problem and the current glycemic control, whether the patient has got rest pain and whether he has a previous history, whether he has got ulcers before and the time and duration it took to heal and the treatment that he has taken. Most of the patients in diabetics also are on polypharmacy. We need to take a drug history with taking care to find about the combination drugs. And secondly, we need to think of patients who are on antiplatelet or anticoagulant drugs. Some of these drugs may need to be substituted if the patients go for surgery. The inspection and examination start by looking how the patient walks into the examination room. It might reveal a high-stepping gait or a calcaneal gait or an unsteady gait. Each of which has got significance. After you make the patient comfortable, you look at the foot and find for any ulcers. And if there are ulcers, you look around whether they have got redness or any blackish discoloration. And look for dryness of the skin, cracks or maceration. They might present with calluses, and if there is a discoloration of the callus, it could mean that there is a bleeding under the callus. You then look for deformities. They might have claw toes or hammer toe deformities or kissing ulcers. And then you look at the dorsum to find whether there are any ulcers. Then you look at the midfoot. You look at the midfoot for any diffuse edema and collapse or guttering in the intermetatarsal spaces, which could indicate advanced neuropathy. The inspection ends with looking at the footwear with which the patient has come. That might reveal a big story. Then we go to a palpation of the diabetic foot. The palpation starts with the pulse. The pulse is felt either for the dorsalis pedis or at the posterior tibial artery. And if the pulse is absent, you just follow the vascular surgery protocol. If the pulses are absent, they need a vascular surgery consultation. After feeling the pulse, you look at the temperature of the foot. A warm foot could indicate infection or it could be Charcot's arthropathy. Also examine the patient's standing so that you find out whether there are any blowouts, venous blowouts or venous disease or pitting edema in the feet. This ballotment could indicate the cause for the metatarsal head ulcers. Diabetes causes stiffness of the joints. A stiff first dorsometatarsal joint could indicate a plantar flexed first ray as the cause of increased pressure underneath the first MTP joint. This is tested in the way this is demonstrated. Normally, the first metatarsal joint has got a range of movement of 10 degrees of dorsiflexion to about 50 degrees of plantar flexion. Any tightness could cause a problem. We then check for the stiffness at the ankle joint. The stiffness of the ankle joint could be due to the tightness of the gastrocnemius muscle or it could be a gastrocsoleus contracture. This is identified by the Silver-Scott test as demonstrated. We flex the knee and then flex the ankle. We then keep a straight knee and then flex the ankle. The test is considered positive when ankle dorsiflexion is more with the knee flexed than extended, and a positive test indicates an isolated gastrocnemius contracture. This is because the origin of the gastrocnemius is proximal to the knee joint. Just as we check for stiffness, we also look for increased mobility at the ankle or the midfoot joint. An increased mobility at the midfoot or the ankle could indicate an ongoing Charcot's foot or a bony destruction in the form of osteomyelitis. A loss of Achilles tendon integrity or function can cause a floppy ankle compared to the opposite side, and it could be a cause for getting heel ulcers. We then go on to do the test for diabetic peripheral neuropathy. Diabetic peripheral neuropathy is defined as the presence of symptoms or signs of peripheral nerve dysfunction in patients with diabetes after excluding other causes. We do two tests. The first test is Siemens-Weinstein monofilament test, which tests for the presence or loss of protective sensation on the plantar aspect of the foot. The Siemens-Weinstein monofilament test uses calibrated monofilaments to do the test. For diabetic neuropathy, we use a filament which could apply 10 grams of force to bend the monofilament. The patient has to lie on the examination table comfortably. It is usually good to demonstrate the monofilament test on the patient's hand so that he could understand what is being asked of him. The patient used to advise to keep his eyes closed throughout the test and to say yes when he feels the touch of the monofilament. The monofilament is held perpendicular to the test point, and with a smooth, steady motion, the monofilament is pressed on the skin until the monofilament buckles. The position is held for about 2 seconds at each point, and if no touch is perceived, the point is marked as negative. Care is to be taken not to slide or scratch the surface of the skin with the monofilament. Once the patient is familiar with the testing process, the test is applied on the patient's foot. Each foot is tested separately, and 10 predetermined points are tested on each foot. As shown in the picture, 9 plantar points and 1 dorsal point are tested, and the results are recorded as positive or negative. Testing over calluses or open wounds is avoided. Vibratory perception testing can be done with a 128 Hz tuning fork. A 128 Hz tuning fork is used to test the vibration by applying the base of the tuning fork, which is vibrating, to the dorsum or the distal phalanx of the great toe, just proximal to the nail. The patient is instructed to say yes once they feel the vibration after application, and now when they cease to feel them. You could use the local vernacular to make this possible. The still vibrating tuning fork is then transferred to the dorsum of the examiner's thumb, and the time interval is measured till the examiner ceases to feel the vibrations. If the duration is greater than 5 seconds, the sense of vibration is impaired. If the patient cannot feel even the initial vibration, the vibration sense is recorded as severely impaired. The clinical examination is completed by checking for deep tendon reflexes. Deep tendon reflexes are used to screen for the integrity of the neural pathways in patients with neuropathy. Common tests that are used are the ankle jerk and the patellar tendon jerk. We then go for radiographs. The basic minimum radiographic assessment required in a diabetic foot patient is a weight-bearing radiograph of the foot and ankle in standard anteroposterior and lateral views. A special wooden pedestal is required for the lateral view projection. The weight-bearing radiograph for the foot is very useful for uncovering dynamic deformities which may not be evident on non-weight bearing views. This we call as standing lateral view. Callosities or ulcers can be marked out with radio-opaque rings to help correlate their position with the underlying skeleton. The lateral view is used to look for any changes in midfoot alignment. A Meary line is a line drawn through the long axis of the first metatarsal and the long axis of the talus. Normally, both the lines overlap perfectly or are parallel to each other. However, in cases of midfoot collapse or a pes cavus deformity, they would form an angle between them and it is called as the Meary angle. The Meary angle can be used to classify the mall alignment as mild, moderate or severe. In inconclusive cases, we go ahead with the magnetic resonance imaging of the foot and ankle, which could reveal early Charcot arthropathy even before structural damages become evident. We then go for vascular imaging in patients with clinically not palpable pulses. A duplex arterial Doppler is a basic minimum test that is required for vascular assessment. Anatomical definition of the vascular tree is well defined by either a CT angiogram or an MR angiogram. And this is useful in deciding if a vascular reconstruction is essential. Or by doing the whole set of these examinations, it is possible for us to come to a conclusion about the line of management that this patient would require.